Hello, and thank you for listening to our presentation on medial tibial stress syndrome's association with a pronated foot type. To begin our research, we constructed the study design question in the form of a PICO: problem, intervention or indicator, control, and outcome. From this, we formulated: does a pronated foot type compared with a normal arch foot cause medial tibial stress syndrome?
Good morning, we are Group 1 and are researching the effect a pronated foot type has on medial tibial stress syndrome. Medial tibial stress syndrome is an overuse injury of the shin area. Yates and White define it as pain along the posterior medial border of the tibia that occurs during exercise and is not of an ischemic origin or signs of stress fracture. Differential diagnosis of MTSS may include anterior compartment syndrome or stress fractures. There are numerous theories which support different tissues being under stress in MTSS. Various stress reactions of the tibia and surrounding musculature occur when the body is unable to heal properly in response to repetitive muscular contractions and tibial strain. Many different studies have looked at the origins of these muscles and their relationship to MTSS. Due to the origins of these muscles, it is believed that traction may be occurring on the periosteum of the tibia. As tension in the muscle increases, there is an increase in strain in the tibial fascia and periosteum. The classic signs of MTSS are tenderness upon palpation over a 4 to 6 centimeter area at the posterior medial margin of the tibia. One theory to the cause of MTSS is a pronated foot type. Often sports people with excessive pronation can develop MTSS due to the pronation leading to internal rotation of the tibia and fibula, causing them to become exposed to repetitive rotation across the fibula and tibia. It also has been proposed that due to an excessive amount or change in the timing or velocity of pronation, the larger extrinsic antipronatory muscles and the smaller intrinsic foot muscles have to contract for a longer period of time eccentrically, and therefore they fatigue quicker. This results in an increase of forces being absorbed.
We used a few different search methods in order to find our relevant articles. First, we looked at Medlin 1948 Ovid database via the La Trobe University Library link. MTSS was used for our keywords. We tried to combine this phrase with athletic injuries, pain, and adults. This showed no results, so we decided to do a broad search for MTSS as a subject heading, including all subheadings, obtaining 13 results. Pronation was used as a second keyword, combining foot pronation, flat feet, with or showing more than 77,000 results. Combining search 1 and 2 limited us just to the one result, so we looked at all 13 MTSS results for possible correlation with our inquiry. Next was the Cochrane Library using MTSS as a keyword, limiting our results to English and systematic reviews. 4 results were obtained, one of which was a systematic review. Our next search method was using Google Scholar, searching MTSS. Without any other limits, this gave us 24,000 results. To filter this down, we decided to place MTSS in inverted commas and add the symbol and pronation, which brought our results down to 867. We decided that the top result was the most relevant.
So the first paper we looked at was a case control study, which is described as a study which consists of two groups of interest: the study group, which usually has the pathology in question, and the control group, which does not have the condition. The reason behind conducting case control studies is to link the problem with possible risk factors, and this is accomplished by exposing both groups to similar environments. In this study, the study group had 14 participants with MTSS, and the control group had 11 participants without. Like the first study, the second paper was also a case control study, this time with 15 people in the study group and 15 people in the control group. Our third paper by Yates and White was a prospective cohort study. Compared to the case control studies, cohort studies aim to recognize the pathology from the point of initial exposure to the time the outcome is reached. The bias involved with this study is that the population being investigated was limited to naval recruits and doesn't speak on behalf of the general population. In this study, 124 recruits were followed during basic training for a period of 10 weeks, and a 3-month injury history was taken into consideration. And our final paper was a Level 1 systematic review. Unlike the previous papers, systematic reviews are literature-based, collecting high-quality research evidence relevant to the question being asked. 2 reviewers independently searched for the articles based on the Oxford Centre of Evidence-Based Medicine. Searches were done using all available database engines, focusing on study selection, data extraction, and appraised methodological quality. Studies on lower levels of the hierarchy of evidence were appraised by the Newcastle-Ottawa scale. However, this article didn't specifically answer our PICO question, it was more of a general intervention.
Results. Inverse relationship between the complexity of midfoot kinematics and muscle activation in patients with medial tibial stress syndrome. In this study, the researcher tested out to compare the structural variability of midfoot kinematics and surface electromyographic SCMG signals between patients with MTSS and healthy control during gait. The study enabled the researchers to find a precise characteristic in patients with MTSS after assessing and comparing the SCMG activation pattern and midfoot kinematic in gait cycle. The results from this study found that subject with MTSS had an average FPI of 3.1 and a control had an FPI of 3.3 with a p-value less than 0.05, as there is no significant difference found in the FPI score among groups. During treadmill walking, the patient with MTSS had an average 1.5 mm larger navicular drop than control with a p-value of 0.77. However, the level of muscle activation of tibialis anterior tended to be higher for healthy subjects compared with MTSS group. So overall, the research concluded that subjects with MTSS are characterized by high complexity of SCMG signal of tibialis anterior and the soleus, but lower complexity in midfoot kinematic. Foot medial longitudinal arch deformation during quiet standing and gait in subject with medial tibial stress syndrome. The purpose of this study is to investigate if MTSS is demonstrated by increased navicular drop and medial longitudinal arch during standing and gait. Subject with MTSS demonstrated a significantly larger navicular drop and MLA deformation during quiet standing compared to navicular drop and MLA deformation in controls, with a p-value of being less than 0.05. During gait, there was no significant difference found between group in MLA angle at heel strike or push-off. However, the subject with MTSS demonstrated significantly larger MLA deformation during stance gait compared with control with a p-value of 0.015. The main findings of this study was that the included subject with MTSS demonstrated increased MLA deformation and navicular drop during quiet standing and increased MLA deformation during gait compared to healthy subjects. The study theorized that the increased MLA deformation will require larger eccentric contractions by the plantar flexors. So in order to compensate this, it is likely to create increased tension in the tibial fascia insertion and lead to MTSS. The incidence and risk factors in the development of medial tibial stress syndrome among naval recruits. The purpose of this study was to respectively measure and monitor naval recruits during basic training to determine the incidence and potential anthropometric foot posture, exercise history, and previous lower limb injury factors for the development of MTSS. Out of the 124 recruits who participated, 40 naval recruits, 22 men and 18 women developed MTSS during the training period, which was 35% of the sample. During 16.2 hours of physical activity done weekly as part of their program, 2/3 of MTSS group developed the condition by the 4th week. In this study, females had twice the relative risk of developing MTSS, with 18 of them, which is 52.9% of the sample, developing compared to 22 male recruits of 28.2% in sample. Also found that recruits with pronated foot type in the range of +6 to +11 were almost twice as likely to develop MTSS as those within normal range of +1 to +5. The results were statistically significant with a p equaling 0.002. 29 MTSS subjects out of the 40 occupied were found in this pronated category. Finally, the research identifies that assessing foot type prior to training may help reduce the risk of MTSS by developing early interventions to control excessive foot pronation. Treatment of medial tibial stress syndrome, a systematic review. This review aimed to assess the effectiveness of conservative and surgical intervention in subjects with MTSS. The systematic review consists of 11 trials. The included trials assess the effect of iontrophoresis, phonophorosis, ice massage, ultrasound, lower energy laser treatment, perosteal packing, stretching and strengthening exercise, sport compression stocking, lower braces, extracorporeal shock wave therapy, shown for ESWT, and pulse electromagnetic field. Out of those, lower energy laser treatment, stretching and strengthening exercise, sport compression stocking, lower leg braces, and pulse electromagnetic field have not been proven to be effective in treating MTSS, as there was no conclusive evidence from these trials. Also, no significant difference were found between the groups for these studies. Although two shockwave therapy studies have shown large effects in the treatment of MTSS compared to control, however, the effect of ESWT had many systematic errors, including the selection, performance, attrition, and detection bias, so no conclusions can be made. In this review, there was no evidence for the effect of any intervention in treating MTSS, as neither studies were sufficiently free from methodological bias to recommend any of the treatment investigated. From all this, the researcher concludes that MTSS is most likely a bony overload injury, so a rehabilitation program that focuses on bone recovery seems most appropriate.
Regarding the evidence collected based on our PICO question, does a pronated foot type compared with a normal arched foot cause medial tibial stress syndrome? We found a moderate connection. This is based on the 4 articles we found and deemed relevant to the measurement. We found 2 limited graded articles as they only included case control studies and therefore they had a low sample size. This resulted in us considering the measurement discussed, however we could not be sure of what variable caused what. We also had one moderate level finding titled The Incidence and Risk Factors in the Development of Medial Tibial Stress Syndrome among Naval Recruits, which looked at naval recruits over a 10-week period. We could therefore include the study and measurement investigated due to the relevance it had with the relationship being pronated feet and medial tibial stress syndrome. Our final article sourced was a systematic review that would be regarded as a strong level of evidence due to having consistent high-level quality findings. This was titled Treatment of Medial Tibial Stress Syndrome, a systematic review. Despite this research being of a strong grade, the measurements within this systematic review did not have a direct relationship with the measurement being investigated, and therefore we could not relate these findings to our question being investigated. We can therefore conclude that from the evidence we've collected, we can grade our measurement of pronated feet and the relationship with medial tibial stress syndrome at a moderate level. This means that we will include the research found, however, it is not of the highest grade available.
Following on, and in summary of the articles researched, it has been shown that having a pronated foot type is a risk factor or component cause that can lead to medial tibial stress syndrome. And as an intervention for the condition, it has been shown that early diagnostic or detection screening and following on early intervention can rapidly reduce the severity or even likelihood of obtaining medial tibial stress syndrome. Intervention options include orthotics, lower leg exercises, any offloading to reduce forces, rest, ice, compression, elevation, footwear, surgery, or taping. Thank you for listening to our presentation.